Among the projects I'm working on is using diagnostic ultrasound to try to better image traumatic brain injury acutely. And this is a Department of Defense funded opportunity. And what we're doing is, at a minimum, seeking to detect the presence of blood in brain based upon maps of how the brain pulsates as a function of its tissue properties. I want to note that received a lot of help from our residents, in particular Ariana Barkley, John Williams, and David Bass. And currently, I'm receiving help from Corey Kelly, who has worked for years with Mike Levitt. So the problem is as follows, as stated by the Department of Defense. They have people who are rather far away from normal medical care in the case of head trauma, and sometimes behind enemy lines. And they have, if someone is unconscious because of some bad event, and the individuals on the ground suspect head trauma, they need to decide where to place this person on the list of, do we evacuate them now? Do we evacuate them later? Do we not bother to evacuate them? It's been put to me that baldly. And there are different classes of bleeds that you guys know much better than me. Epidural and or subdural and or subarachnoid hemorrhage are more or less amenable to treatment, surgical treatment, with relatively good outcomes, while interparenchymal bleeds, the outcomes aren't so good. So they would like to know, the military would like to know, A, is there any blood in the brain would be the minimum viable product. Better would be, is there blood, significant blood, whatever that means, within the parenchyma versus along the edge? That would be the minimal viable product. What I'm trying to do is build an imaging system so the person in the field can make a decision. Worst case is I build a detection system. So they want it small. They want it about the size of an iPad or phone. And while I have one, there it is. It's the size of an iPad, but double thick, made by a company called Terrason out of Boston. And it's a standard, an unusually small form factor, not unique, but unusual, and has complete diagnostic ultrasound capabilities. So the underlying physiology that we measure with ultrasound is as follows. So I'm assuming you can see my cursor. On your left is a B-mode image through the temporal window of a healthy test subject. On the far side, there's a bright streak, which is the contralateral skull. This is an axial view near the brainstem. And if you zoom in on a pixel and do some basic analysis, that's unusual for ultrasound, but not unheard of, you can measure the brain moving with the cardiac cycle with peak displacements in the order of 50 microns or so. That's a typical number. And just as a point of reference, your average, the thickness of an average hair is about 100 to 120 microns. So ultrasound can pick up rather small displacements. And what we're trying to do is develop a map of what's going on within the cranium, where we hope to pick up differences in brain tissue versus various kinds of bleeds. Oops. So here on your left is that same B-mode image as a function of time. And on the right is a heavily averaged image, a set of images creating a movie. So red is towards the transducer, blue is away from the transducer, and what I believe you can see is broad displacement of the two hemispheres of the brains, of this brain rather. And our analysis for the last couple years or so has been focused on digging deeper into this kind of map to see what we can identify as far as bleed versus not bleed. So to make this happen, and thanks to you guys, we have access to head trauma patients, a lot of subarachnoid hemorrhage, image from falls of old people like me, and some motor vehicle versus tree people and all the rest of it. And a hard step we do, but that we do, is we align an ultrasound image with a CT image. These are clinical CTs. A screening step for our study is that patients have CTs because they have suspected head trauma. And we put in a lot of work collecting this ultrasound image plane, projecting it onto the CT volume, and then coming up with a plausible CT plane that we overlap and sometimes project onto the ultrasound plane. The next figure discusses this more carefully. So this on your left is, for our 7th patient, is a B-mode image, which doesn't tell you a whole lot about brain. So this is a ultrasound image based upon how much sound scatters back from various structures within the brain, particularly the far skull, and typically it's fairly useless. And on your right is our best sense of the projection of a volume of CT data onto the plane where we collected the ultrasound. So there's bone, there's blood, there's ventricles, etc. For a lot of our work, this very important step gives us our ground truth. When we analyze a given ultrasound image or a collection of ultrasound images, we're comparing it with what we believe to be the best projection we have in hand for this CT image. So for example, we'll do some studies, and I'll talk about them next in my remaining few minutes, where we'll say, okay, bone is here is in red in the CT. Wherever this projects onto this pie-shaped chart, that's where we're going to say there's bone. This is where we're going to say there's ventricle. This is where we're going to say there's blood. And we're going to try to understand the different properties of brain pulsation in those regions as defined by CT. So our first set, just as a repeat from what I talked about last time, so I'll go very quickly, is what can we learn by analyzing individual images? And so what we did, again, is we define, this is the projection of a CT image onto an ultrasound image. Yellow is blood, husky colors. Purple is not blood. And then we ask, what does the pulsatility as from various measures look like? How does this tissue pulsate in yellow versus how does it pulsate in purple? And for this particular case, we define an average pulsation metric. Details don't matter right now, in purple versus in gold. And then we ask for pixel by pixel, how do the individual brain tissue pulsations compare to the average? And then we get this figure in the lower right, which is essentially that, at least within a given image, where we have a sense of what an average should look like, we can pick up this epidural bleed with some sensitivity and specificity. This sometimes works and sometimes doesn't work, to be fair, but it's teaching us about potential differences in the pulsation of brain and of bleeds in the brain. Here's another example. I'll return to this multiple times. Same idea. Whatever the CT declares as blood, we measure what an average, or quote, average brain tissue pulsation means in blood. Same for non-blood. Then we take those two metrics and then apply it everywhere. And sometimes they compare really well, and sometimes it doesn't compare so well. Giving us hope that there's some difference in brain tissue pulsation when there's a bleed versus when there isn't a bleed. This is by no means perfect. Even within the lesion that is quite prominent, we miss these subarachnoid bleeds entirely. And maybe they're different, which is going to be one of my questions to you at the end. And here's another example, same patient, a different imaging plane, therefore different CT plane. It detects this big bleed. There's some hint of some subarachnoid hemorrhages with lower probability, sensitivity, and specificity. That's area under the curve, I should say. Not bad, not bad. It works sometimes and sometimes it doesn't work. All right, so that's nice. Given an image, given a retrospective definition of, an average in a bleed area, an average of pulsatility in non-bleed area, we prospectively, for this image, predict all over the place, and we get sometimes some good results. What we're working on now is intrapatient perspective analysis. We have anywhere from 6 to 30 such images. And the question is, for a given patient, at least if we take a bunch of images, can we learn from a subset of the images and use it to predict what's happening in the remaining image? So in the case of a single patient with 30 ultrasound CT image pairs, we do this projection of the CT image onto the ultrasound image. We say, okay, this is blood, this is non-blood. We know that because of this projection. We do that for 29 of these ultrasound CT image pairs. And then we predict, we develop an algorithm from that, what's blood, what's non-blood, and then we test it on the 30th image and we round robin through all the 30 images. So we wound up with 30 test cases, up to 30 test cases for a given patient. Well, here's an example. First, the CT images. They have an epidural bleed along here. They have a interparenchymal bleed here. Red is the CT image, and this is a series of 5 CT images that have corresponding ultrasound images. I should have said it's actually 8 seconds worth of ultrasound, so it's a movie, so we could watch the brain pulsate. Along the bottom row is also the CT image, where we focused on the part that's parenchyma, and we've said, okay, light green is blood within a range. We're going to call it blood, just it's all blood. There's the interparenchymal hemorrhage. And if it's not blood, it's brain. So in principle, these contain the same information, but it's idealized. There's gradations, there's my question for you later, in tissue properties when there's a bleed. How much? I really want to know. And this is what the CT looks like when you say, okay, if something's in the range of blood based upon Hounsfield units, we're going to call it all blood. And I'm going to compare this bottom row to the corresponding ultrasound images in this predictive way. So again, along the top row are 5 CT images, same patient, slightly different positions because we apply the ultrasound 5 or 6, in this case 30 times. And along the bottom are the predictions for blood in red versus non-blood in black. The good news is at times we can catch these epidural bleeds. At times we don't. I'm assuming you're following my cursor. There are lots of punctate false positives of blood, and we miss this interparenchymal bleed. This is typical of our results so far. We're really good at finding non-blood, and we sometimes do a decent job with some of these bleeds. This is relatively recent research. So I know I have very little time, so I'm going to go straight to my question. We're making an assumption here. So here's that interparenchymal bleed again. This is the full CT image with gradations in Hounsfield units. Here we have effectively said, is something bleeding or not bleeding? And here's a close-up of this interparenchymal bleed. For analysis, when we assign something as blood or not blood, we do so based upon a range of Hounsfield units from the literature. And we assume everything in that range is blood, for example. That's the gold yellow color, or everything in the range is not blood, in this case, purple. I'd like to know what you think of that assumption. That is it really true in your considerable clinical experience that interparenchymal or subdural or epidural bleeds are entirely blood versus non-blood? Are there circumstances under which there are a mix of blood and tissue, especially acutely? That's my question for the audience, and I'd like to have a minute of someone's opinion about that. Rich, can you help me out?
Well,
Pierre, I have a question, Pierre. This is kind of a simpleton tangential question, and I apologize, but even though you said your B-mode squamosal window was useless, it seemed pretty good to me. And it seemed like if you had bilateral squamosal windows and did some post-processing and used Sir Jeffrey Hounsfield's idea, which is density, but you using how hyperechoic it is, you could just post-process and say, here's blood and here's not blood. Because it seemed like a pretty darn, you didn't like it.
I wish that was true. I've tried that, and it hasn't thus far borne fruit. Not from lack of effort.
Hi, Pierre. It's terrific to look at that. Thank you for the presentations, Christoph here.
Christoph, I owe you a picture, by the way. I owe some analysis. Just so everyone can know that.
Don't worry. Don't feel bad. Don't feel publicly bad about it. And I definitely didn't want to shame you here right now. Great talk. I love it. Hey, one thing is, like you're looking at brain pulsations, right? And then now you're like asking us, why is it not the predictive value is not better than it is? And my question here is right now is, have you looked at the patients where you're able to predict and sort of relatively clearly can see the hemorrhage versus not? My guess is that, there might be a difference in all over sort of, a brain fullness / ICP, so that in certain patients with very severe hemorrhage, the density of the brain will be very similar to the clot as they have raised ICPs. So I think it would be interesting to look at the whole set that you have, look at the patients where you can predict and see it versus non, and there might be something to learn from there.
Thank you. I believe for the vast majority of our patients, none of them have an ICP monitor. But, okay, but more broadly is look for commonalities in their medical condition. I agree.
Well, I think you can see, the effacement of the sulci and other signs of increased ICP, or the basal cisterns if they're full. I mean, there's a lot of signs that you can at least guesstimate. I think that would really propel you forward if that's an issue. In fact, it would be a very interesting diagnostic issue.
Thank you. We will do that. So how homogeneous is an intraparenchymal bleed, for example, in a brain on average? Any thoughts from anyone?
I don't think it necessarily is going to be homogeneous. I mean, the clot itself is going to have some that's more liquid than the rest. And when you're taking these out, you can see that. Some of it depends on the age too. I mean, if it's over a couple of hours, some of it starts to organize a bit more than others.
Thank you, Andrew. So, but it's still clot. It's not, there aren't bits of brain in there as well on average.
It depends how they got it. I think in trauma, you'll see tissue mixed in when you're sucking it out.
Yeah, in trauma, you'll definitely have areas that are coalesced contusions. You'll have areas that are pure blood. And your boundary conditions will change as the edema develops and shift occurs, and the brain evolves over time. We certainly have lots of early up patients with ICP monitors and some guesstimate of compliance, at least qualitative guesstimate of compliance. But certainly early on in trauma, a lot of times what looks like a red clot later often looks mixed density up front.
Yeah, I think what Randy's saying is there are no pure lesions except maybe an epidural or subdural. And that's the challenge you're facing. I mean, if you can come up with a paradigm for subdural and epidural, great. But there's contusions and DAI and so on. So you have a challenge in the heterogeneity of some of these lesions for sure.
Here, I just have one thought to share. I think if one of the goals of this is to identify like large extraaxial lesions that would be, an indication for urgent transfer for surgery.
Exactly that.
Yeah, so it could be interesting to see if adding a layer of Doppler onto this helps to identify like the margins of the brain parenchyma. So, for example, if someone has a large subdural or epidural, the surface of the brain is going to be shifted by that away from the bone, and so you might see cortical vessels farther away from the bone surface than you would in somebody without such a extraaxial lesion. I don't know if the resolution is good enough for that or anything, but it would be certainly an interesting.
Thank you. That I will try. I can try.
And I know what.
This is my last slide, John. Rich, I'm going to add edema. David Bass said you better add edema, and I'm going to do that next. Take into account heterogeneity, per this discussion, as I feared, move more for given predictions, given data from a given patient, set of patients, can we predict brain bleeds, et cetera, in other patients, and then eventually move towards real-time prospective testing. That is my talk, and I appreciate your time and comments.
I talk, we're kind of going over some of the work I'm doing. A lot of this is in conjunction with Jeff Ogerman and Jeff Herron, and I've sort of tentatively dubbed our group the following. It's kind of long, but if you just treat it as an acronym, it makes a lot more sense. So just in general, as an overview of what we're trying to do, basically we kind of have two big questions. One is, how do neuromodulatory therapies work? And here, neuromodulatory, I'm going to lump in just anything that I do. So some of this we're going to try to extend to things like pain, but then also lesioning for epilepsy, for example, resections, or even tumors, what happens after you take out tissue. Just basically how does the rest of the brain respond to some of our interventions? And the next would be, how do we make these types of therapies better? In terms of the tools in our lab, basically we are doing studies in humans, which I mean, I think that's one of the better ways for neurosurgeons, residents to kind of leverage our access to the brain. It also kind of beats having to try and maintain animals or cell cultures. It's much closer to kind of what we're dealing with every day. So I think that's very helpful. In terms of the other tools, we predominantly are looking at electrophysiological changes. So you can measure voltage in the brain. It changes over time. And there's various techniques to kind of extract information from that. And then you can also use stimulation to evoke responses. And that's a big part of what we're doing. Another tool is advanced imaging. Basically, we're looking for non-invasive means to evaluate sort of distant parts of the brain. So structural and functional connectivity. This sort of on the readily available end of things would be things like fMRI and DTI, which we can often get reasonable quality imaging in our patients. And ideally, research magnets, you could get this kind of imaging on 7T magnets. The dedicated disc imaging center can do a lot of this stuff. But for the most part, I just in general have tried to adhere to the kind of ORs or laboratory type stuff. So if we can get it on clinical, in terms of a clinical quality and get valuable information from that, I think, again, that's kind of how we can leverage our access to disease and the human brain. The last component is our close collaborations with the engineering and computer science departments. There are a lot of ways to use the increasing computing power to extract information from electrophysiology and imaging, and combining the two. So just start with a couple of things where we've gotten some results and are currently working on getting results out. I think when we did this a couple of years ago, and I did talk about this work, but in terms of DBS for Parkinson's disease, we've been doing this for decades, and there's still a fair number of open questions in terms of how it works. So I think this is an example of the type of work that's possible in the operating room without too much extra, I don't want to say too much extra effort, because you can see from the author list, a lot of people worked on this, but really the only thing different that we're doing here is including a cortical strip during implantation. The rest of the data gathered is pretty standard. So what we did was looked at cortical responses to stimulation during implantation and during test stimulation during DBS implantations. And again, we didn't really change much of how we did it. Patients were still asleep. But we would make our burr hole, extend it slightly, open dura at a separate site, kind of behind where we usually would implant the electrode, and then pass this 8 contact strip back over somatosensory and motor cortex. We'd then run an SSAP, just kind of like we would do for motor mapping. You can see the responses here. We get a sense of where motor is. And we had, I think, for this paper, 7 or 8 patients, or actually like 9 patients. And you know, these are the electrode locations. So we're not trying to be too precise, but you get coverage of motor cortex. You can see my cursor or not, but over here you can see electrode locations. And these were all targeting STN. Once the electrode was in place, we would run a series of test stimulations. So, you know, between these electrodes, they're numbered 0 to 3, and I can go into why that is, but kind of irrelevant for now. But you stimulate between each of the DBS electrodes, and you can, while doing this, we would run direct cortical stimulation to evoke MEPs. And so basically the paradigm was we'd get a baseline for a threshold for an MEP, for a consistent MEP response. And again, this would be just, I mean, we had basically the rehab folks who do our motor mapping do this. Let's say that the threshold is about 10 milliamps, you get a fair amount of response. We would then randomly stimulate between 5 and 15 at the cortex, and in the meantime, do deep brain stimulation in the subthalamic nucleus or nearby. And just measure whether or not you get a motor evoked response. And so at that threshold, it's kind of defined as where you get a response about 50% of the time. And so you run through these, the series of stimulations, both at the cortex and at the deep brain sites. And you can build these response curves. And so in the bottom left here, between contact 2 and 3, so sort of more proximal on the electrode or not as deep in the brain. What you see is when DBS is on, these gray lines, all basically for this patient, the motor threshold is kind of right around 11. But during DBS at this particular site, you see that it takes a lot less stimulation to evoke a response. And so we did this in about 10 patients, and we fairly consistently saw this leftward shift in the response curve, meaning that with DBS on, it takes less to get an MEP. We then, over here on the bottom right, co-register this with a preoperative MRI. We have DTI imaging, and so we would extract tractography between motor cortex and spinal cord to look at a corticospinal tract, as well as between the STN itself and motor cortex to kind of define the hyperdirect pathway. So there's a monosynaptic connection between motor cortex going down to the subthalamic nucleus. And basically what we found is this shift is a result of the simulated stimulation field overlapping more with this hyperdirect pathway. And there's been some evidence that, you know, this is linked to clinical response from other groups. But basically what we're showing here is just that this is an anatomically specific location, both by sort of gross anatomical markers, sort of the upper right here, where the red electrodes show where we get the response. We know we're just above STN and the white matter there. And again, using tractography kind of more directly look at the white matter. So all this work came out in movement disorders this last year. And it kind of, I think, is a good example of what we're trying to do in terms of looking at how DBS works or how stimulation affects the brain or distant sites like the cortex, where we do stimulation, look at evoked responses or changes in evoked responses, and then combine that with imaging data. The next thing I kind of wanted to talk about was just a sort of future work that's not directly that, but related to laser ablations. Again, kind of looking at what we've done and how that affects sort of distant sites in the brain and trying to link that to clinical outcomes. So I think most of you have been in laser cases, but for those that haven't, this is a procedure we do in the predominantly in the MRI scanner. Here in the upper left, it kind of shows what happens. You have a laser catheter. So this is a sheath with a fiber optic fiber that allows you to heat tissue parenchyma using the laser. The MRI scanner gives you a moment-to-moment estimate of temperature, and the computer software here will give you a damage estimate. And basically we use this to try and remove as much hippocampus and amygdala as possible to treat epilepsy. And so this is kind of a cartoon of the process here. You can see tissue heating, the computer telling us, okay, this is how much of the amygdala here has been ablated. You can then slide the catheter back a little bit and repeat the process. And this is kind of a schematic of the laser ablated volume. So on postoperative imaging, you can look at the contrast enhancing portions of the scan and kind of build this little 3D model here. The goal here, basically for the surgery, is to make people seizure free. The advantage of this over traditional temporal lobectomy is that you don't take out all the lateral temporal lobe. So from a side effect standpoint and cognitive outcomes, this is better than doing a temporal lobectomy. It's a lot less invasive, and so you have about a 3.2 millimeter twist drill burr hole instead of a craniotomy. So essentially everybody leaves the next day. Recovery time's quicker and risks are lower. So the infection risk is essentially zero. It's about a 0.5% chance of bleeding from putting the catheter in, but other than that, it's clearly less for the patient to go through. The downside is it's less effective than a temporal lobectomy. So our seizure-free sort of class 1 outcome rate here is about 45% for all comers, a little bit higher if you have MRI-defined MTS, but it's difficult to when you're at 50-50, that's kind of, you start to ask the question, well, how do we tell who's a better candidate than others, as opposed to, the 65-70% that's kind of in the literature for temporal lobectomy outcomes. And actually, if you look at MTS, I think temporal lobe outcomes are even better than that with an open surgery. And part of this is just, well, how much brain are you taking out? So the question here, the problem is there a way to use other information that we get to better predict outcomes or potentially better plan trajectories? With this single catheter, you're pretty limited in your approach. You can't stick in additional catheters. That just kind of slightly increases the chance of complications, but also just increases the complexity of the procedure. So we don't tend to do that for everybody. But if we were to, is there a way to kind of predict how better to do that? So our thought here was to look at how the tissue in this area connects to other parts of the brain, and whether or not that can give us information on where to ablate the brain. And so our process, basically, we create these simulated lesions in patients, or not simulated, the lesions, we extract where that is. We segment the brain here. So in the upper right, there's various programs for labeling different parts of cortex. I think this is actually from, it's a program called GIF, but it's uses particular techniques to label these different parts of the brain. We call that parcellation. So it labels different parts of the brain. And then you can merge this with the patient's preoperative diffusion imaging. So and basically use tractography to create to measure how connected different parts of the brain are. And I'm not going to go into exactly how that works, because to a certain extent you don't have to know. There's computer programs that kind of do it for you. But what you can do is generate something called a connectome. So here in the bottom left here, there are these little balls here represent the nodes of these different labeled segments of the brain. And the lines kind of represent how connected they are. And this one down here is not color coded by anything in particular. But you can see you get this network. And what you can do is simulate what changes in this connectome once the lesion is in place. And so what you see for this laser procedure, essentially in the bottom right here is these are the connections that do show some change in strength if you ask the computer to generate the connectome, but exclude any tracks that travel through this region. So it's not a direct measurement, so we're not doing this after the surgery, but we're using their preoperative data to say if we do this and we pretend that this part of the brain's not there, what happens to the connectome. And then we run this through some machine learning algorithms to try and extract predictive features. So if we eliminate certain connections, is that more or less predictive of seizure freedom? The atlases we use for parcellation, they'll have anywhere from like 80 to 150 different brain regions labeled. And so if you do the combinatorics, you're looking at a couple, 3, 4, 8,000 different connections to look through. We do a lot of laser ablations, but we don't have anywhere near the number of patients where we can run kind of this traditional statistics to look at whether or not these things are predictive. And so what you need to do is something called feature reduction. So we run a sort of a pre-logistic regression to see, okay, well, which things seem to be predictive. We'll look at only those, and then we refine that with another machine learning algorithm to try and kind of pull out, look, these are the seizure-free patients, these are not. And so running through this sort of stage algorithm, we get about an 80% area under the curve for the ROC curve. So 80%, that's kind of middling. But in general, we do these surgeries on people. We only do these surgeries on people we think are going to be seizure free. So sort of the baseline is about, in our case, about 43% accuracy in terms of the clinical features. And so this represents a significant improvement. But more interesting is that this type of model, once you create this model, you can, because it's just based on preoperative imaging, you can kind of just use this to simulate whether or not a given a new patient can be, like which tracks should we look at. If you look at the predictive features that we extract, there's I think like 16 of these. Actually, this is actually slightly older, so we've gotten it down a little bit better than this. But you'll notice a large number of these connections involve the ipsilateral entorhinal cortex. And anatomically, that makes sense because that's sort of an area where you may get more or less ablation based on the location of the catheter. Previous sort of studies on trying to figure out how well laser ablation works tend to show that the variation in the anterior portion of the ablation, it kind of accounts for the variation in outcomes. And so one, this kind of matches previous data. Two, it does tell us that this region is pretty important in terms of determining seizure outcomes. And so if we're going to try to simulate responses, this type of model is potentially helpful. And we started doing that, kind of changing the masks that we use for the laser ablations to look at whether or not people who aren't seizure free with their actual ablation, hey, if we ablated a little bit lower, would they have been seizure free? And basically now we've moved on to trying to validate this in the next sort of round of patients that we accrue.
Thanks, Andrew. Can we just wrap it up? Melanie is going to.
Sure. The other thing is just kind of looking at existing traditions and whether or not we can make them better. Just a quick, we've talked about closed loop DBS before in the past, but basically what we can do is turn DBS on and off based on whether or not a patient needs it. And so for essential tremor for this patient, for example, he has a cortical strip implanted as well as a regular DBS electrode. And you can see as he moves his hand, he starts to shake, the DBS goes on, the shaking stops. And that's all based on his brain signals. We've kind of moved on from this rig here where he's connected to the computer to people who are walking around freely and just their DBS generator with their onboard computing can do that. And we're going to be closing that stuff on. The next step's kind of looking to see if we can use additional data from this strip to predict what the person's doing on a broader scale and using a deep learning sort of a convolutional neural net to do that. And we can actually pull out whether or not somebody's sitting, standing, or walking based on the single channel and do something similar. So that's really exciting. And basically the gist of this slide is that we do better with this neural net than traditional machine learning techniques. I'm not going to talk too much about this last bit, but that's kind of the basic gist of what we're doing. Is one, can we figure out how what we do impacts the rest of the brain, and then can we make what we do work better?
Briefly, hi everybody. I only have 10 minutes or so, but we have 4 ongoing projects with IRB approval, and I just wanted to familiarize everybody with the work in case anybody has suggestions or advice along the way. I made a slide for each, just one slide each. There's no way to talk about any of this stuff in 10 minutes, and I want to leave it open for questions for my colleagues. We're doing autologous mitochondrial transplant. The R03 relates to viral reactivation. We're doing some technique refinements in the angio suite, and then the clot bank. So the first thing I want to mention is the work I'm most proud of. We just got a really cool paper published on the animal work this week. Mike and I had been working on this for a couple of years. This was the gist of my Rockefeller Fellowship, which is, can we take healthy mitochondria from skeletal muscle and implant it into ischemic tissue and improve the bioenergetics of that tissue. And this is based on work done for ischemic hearts in animals and humans. So we completed the animal work with some colleagues at the University of Virginia, and we got approval to proceed with our first in-human trial. So a little delayed because of COVID, but I think we're going to start recruiting soon. So just from this slide, we take a little bit of muscle at our access site. In the angio suite, we isolate the mitochondria. Then we put it directly back into the catheter right at the time of reperfusion. And takes about 40 minutes, maybe a little bit less. We send an aliquot for quality control to measure and monitor viability. And then the follow-up is done primarily by imaging, because this is a phase 1. We're not looking at effectiveness yet, just safety. That's the first project. Second project is the R03 work, and this is more to do with vasospasm. This is a conversation I've been having with Will Longstreth for 20 years and finally found a way to study it. I also believe this is the cause for paroxysmal atrial fibrillation, a couple other things, and that is that we have viruses, especially the whole family of herpes viruses, that live in our autonomic and sensory nerves. And just because they're connected to skin, we tend to, in epithelium, we tend to see them most as blisters on the lips, genital places, skin, you know, BZB or HSV1 and 2. But turns out that these autonomic and sensory nerves are also connected to a whole bunch of other things that we don't see, but we may be seeing some of the effects. And so the theory that I have is that after this slide will tell you on the top, after primary infection, herpes kind of lives in the sensory and autonomic ganglia. When you have a catecholamine surge, we know that catecholamine activates the autonomic and sensory nerves, stimulates the ganglia, and it causes, you know, lytic form or viral reactivation. I know these are kind of gangster drawings in art, but just trying to make them schematically very simple. The reactivated virus then travels along, irritates nerve. It doesn't enter the bloodstream, and it doesn't enter the CSF, which is why you don't get meningitis, and you don't even get virus in your bloodstream. Typically, you can test for it, but you don't get it. You get it at the source of the lesion. And what happens is that it irritates the perivascular nerves, I believe, that innervate the basal cerebral arteries. And so you get kind of a disordered input to the tone of the vessel, and you get vasospasm. And the way that we're going to measure that, obviously you can look at some of the, you know, traditional things, TCDs, imaging, but oops, sorry for the typo there on innervation. Because these nerves also share innervation with glands, not only with the blood vessels, we see viral shedding, or we will see viral shedding measured from saliva and tears. And I believe that there will be an increase in quantity starting at day 4 and then extending to the time when the virus moves back into its latent state, which takes usually about 2 weeks, so 7 to 10 days for it to simmer down after it starts up. So we're measuring catecholamines at the beginning, and we're testing saliva and tears during the patient's hospital stay. And this is for all subarachnoid hemorrhages after aneurysm. We're looking for maybe a biomarker. Third bit is, as you guys know, I'm pretty passionate about stroke. That is a little bit of, you know, my background. And I started to think a lot about what are we doing with our clots. And I felt like they were a valuable source of information that were just medical waste. And so when I first started my fellowship, kind of towards the end of 2017, I got IRB approval to keep all of our clots at the University of Washington, venous and arterial, peripheral, so the heart guys, the body guys. I don't speak with the vascular guys too much. We're not keeping peripheral leg clots, but everything else we have access to. And what we do at the Clot Bank is we work through partners. So basically all we do is take the clot out and then find partners to do their projects. We have five actually ongoing projects with variable funding, depending on what the project is. It's pretty simple. We take the clot out and we store it. Depending on what the project is, it's a certain type of storage media. And then we pass it along to partners to do analysis, which is the perfect kind of research. All we do is our job and then send the materials away. The one that I'm working on specifically is we're doing next generation sequencing of clot microbiota, because we found that oral bacteria are present in most of the clots we remove from the brain. And it's a very interesting rationale, and we have some theories about that. The second project, we're working with radiology and Siemens and others to try to improve our capacity at the time of imaging to predict the morphology of clots, which helps both in the prediction of instrumentation and stuff that we use to remove the clot, but it can also help determine what the origin of the clot is and maybe improve our diagnostic ability for secondary issues. The third thing we're looking at the Clot Bank is a really cool project with a group called Sensome, which is using impedance microsensors. And they make two things. They make a wire that's not yet available in the United States. It's in Europe, that at the tip of it has an impedance microsensor, and it can detect what the clot morphology is while you're doing the procedure. What we're working with them on is a little box that it's not a wire, it's a separate device. When we take the clot out of the brain, we put it into a little box, and it does the same impedance testing, and it tries to identify tissues. And it's using machine learning from now many thousands of clots and tissues that they've analyzed, and we're working with other institutions as well on this. Pretty cool. And then the fourth area is a recent one. The School of Nursing is doing a study on the lipid concentration within cerebral thrombi and how that relates to 6-month outcomes on certain other issues. And so these are all the things that we're finding in clots coming from the brain. And I believe the future is gonna give us a lot of information about that. The last thing that I'm working on is a partnership with our ENT colleagues. And this is really ahead of the IA therapies that are available. And this is more extending the work that we do within our own field of endovascular. We do a lot of embolization preoperatively, as you guys know, and many of you refer to us for meningiomas and other paragangliomas, things like that, ahead of it. But with malignant cancers in the brain, it's tricky to do embolization. But in head and neck cancers, particularly squamous cell carcinoma, we're looking at preoperative embolization as a phase 1 study to later go on and do IA, the immunomodulatory therapies, not AA chemo, but immunomodulatory for tumor priming within the tumor bed. So just a little schematic of this. You guys know how all this stuff works. We put a catheter in the femoral artery. We identify the hypervascular tumor. If it's suitable for embolization, meaning all the vasculature works and it's not connected to things that are dangerous, our current study we would embolize it and see how you do. In the middle, I just used an image that we had done and kind of superimposed what the process looks like, where we would identify within the hypervascular tumor the feeding vessels, embolize it with small particles. Our current phase 1 to look here is something you guys are all familiar with, and we use in other parts of the brain and other parts of like dura and stuff and other liver body parts, where we use an embolic material. In this case, we're using Lipiodol in one arm and Lipiodol plus PVA, which is these small alcohol particles, in another. You can see post-embo that the main thing this does is just devascularize the tumor without actually inserting any treatment. This arm doesn't have chemo or anything like that, or this study doesn't. The benefits that have shown in other studies and that we're also predicting will be the case for head and neck cancers, squamous cell cancers, is that you get what we all know, right, and why we love it: diminished blood supply to the tumor, less intraoperative blood loss, shorter OR times, and then later, this is a really important one for the malignant stuff, is that embolization doesn't really affect future treatment. So those are the 4 areas. You can see at the bottom of each of the slides, hopefully you guys have all seen that, the partnerships and the people that we're working with. And I'll just put it back on the first slide so you can see.
I have a question. Melanie, great work. You really got your fingers on the pulse on a lot of things. I was interested in project number 2, the viral reactivation. How are you going to test that catecholamines activate the herpes virus? How, I mean, temporally related, or are you going to measure the virus?
Yeah, I think it's difficult to, first of all, many of the patients, as you know, are on pressors and other medications that may affect plasma catecholamines. So it's difficult over the course of their hospitalization to correlate that. We're testing plasma catecholamines, fractionated plasma catecholamines at the time of admission. I actually don't think the stimulus is as important to figure out because we're never going to be able to stop whether it's a cortisol or a, whatever the thing is, we're not going to be able to stop that from happening at the time of ictus. I think it's, we added it on later to just try to correlate some other value to see if we could. We're testing at 5 time points, which is at the time of admission, at hospital day 3, 7, 10, and 14. We're testing plasma catecholamines and eye, right and left eye, and salivary swabs for PCR. And we're going to see, my guess is that we're not going to find a huge amount of association, or the plasma catecholamines are going to be all over the map. I think maybe the admit catecholamines will be high if they come in, within a day.
But how do you quantitate? I guess is your principal aim to quantitate the amount of activation of herpes? All of a sudden, the herpes quantity goes up tenfold. I mean, that would be interesting. That would prove at least give support to your hypothesis. I guess I'm just trying to understand. I mean, it's
the hypothesis, to me, the hypothesis of which particular physiologic stimulus is causing the reactivation is not as interesting to me as correlating the quantity of viral shedding that you have.
That's what I'm saying. Yeah. So,
right. So we're going to measure that so every day we measure TCDs in our patients, and we'll be able to see the change and sometimes they get imaging and whatever, but we every day get TCD, and we can correlate the flow velocities and other metrics that we collect on the TCDs. We use some of the ratios and things to tell mild, moderate, and severe.
And the viral load and how you.
And the viral load, yeah. The viral load in the lesion, you're not going to get it in serum. So the viral load within the saliva and the tears that are secreted, from the same nerves that control the blood vessels. So the theory goes they share nerve supply, and you should be able to, if it's really causing the irritation, you should see a peak at the time, anytime there's a trouble, right? Anytime there's reactivation, you should see a peak. And then at the peak of vasospasm, our guess is that you're probably going to see a correlation with quantity. I don't think in tears it'll be as much, but it's been reported in experiments that you can. So we're testing tears, but I think in saliva we'll see the biggest difference.
You're great. Any other questions from the audience? There's a lot of ground to cover.
I know. 10 minutes. I didn't go through all the theoretical stuff and all the animal models, but.
Melanie, this is Shekhar. Good morning.
Hi, Shekhar.
Wonderful concepts. With regard to the antiviral or the viral etiology of vasospasm, are you planning any experimental models? Because the number of experimental models for vasospasm, I've done some research there before. But if you do have an experimental model, then you can try test out some antiviral therapy.
So there is in animals, right? This is, I guess, the first time that this has been proposed to try in humans to see if there is a correlation. I think that doing antivirals is a little tricky. You'd have to do it at the time of admission, right? So we'd have to be able to suppress it. It's typically a little challenging, so we'd have to get a study right away and suppress them as they come in. But in theory, if we can identify that there is a peak, we can go on and do an antiviral trial. We can go on and, like Rich was suggesting, go and look for the exact stimulus that's causing the reactivation, things like that. And it may end up to be VZV and not HSV. So I mean, it could be any of the viruses that live in the ganglia.
My point is that if you create an experimental model, you can test out antiviral therapy. The antivirals are relatively safe to administer. If you can prove the concept in animals, you can certainly start a trial in humans where the antivirals are started, right after admission.
Mm-hmm. Yeah.
The other thing is you can, in patients in whom we perform surgery, for instance,
Thank you.
You can measure, we do have clot in the subarachnoid space, and we can give you tissue from the aneurysm wall, etc. You can measure concentrations of the virus and see if it is correlated with anything, because we do know that vasospasm severity is correlated to two things. One is the clot load. The second is somehow related to patient's age. We see it a lot less in people with very stiff vessels. That's probably related to reactivity. So I think that those are things that can advance your goal.